Hello, everybody. I hope you're all enjoying the CanSAGE at Home virtual conference. My name is Samantha Benlolo, and I'm a clinical fellow in minimally invasive gynecologic surgery at St. Michael's Hospital in Toronto. Today, I'll be talking to you about predictive variables for post-operative opioid requirements following hysterectomy. As many of you know, across many surgical specialties, patients are prescribed more opioids than they consume following surgery. Specifically, following hysterectomy, patients can receive between 2 to 4 times the amount of opioids than they actually consume. Prescription opioids are often the patient's first exposure to opioids, and unused opioids are usually stored or discarded inappropriately, leading to risk of diversion, hoarding, and/or substance use. Why is this important? Many of you are aware of something called the opioid crisis, an international crisis relating to opioid-related harms. Specifically in Canada, there have been 11 opioid-related deaths per day since January of 2016, and this is an ongoing problem. Predictors of opioid consumption following hysterectomy include history of chronic pain, anxiety, depression, pain catastrophizing, younger age, and smoking. Being able to predict post-operative opioid requirements can help prevent overprescription of opioids without compromising pain control. The objective of our study was to identify predictive factors for opioid consumption following hysterectomy by determining the relationship between perioperative opioid requirements, preoperative pelvic pain scores, and patient variables. We conducted a prospective cohort study of 191 women undergoing hysterectomy at a tertiary care academic hospital. Inclusion criteria included age over 18 years old, sufficient knowledge of the English language, and hysterectomy by any route, including laparotomy, laparoscopy, vaginal or robotic, with or without additional procedures. Exclusion criteria included malignancy, except for low-grade endometrial cancer, and emergency hysterectomy. Preoperatively, all patients completed the pain sensitivity questionnaire, pain catastrophizing scale, and the numeric rating scale. Cumulative opioid consumption, calculated in oral morphine equivalents, was the sum of opioid consumption recorded during 3 time periods: intraoperatively, in the recovery room, and in the first 24 hours postoperatively following discharge from the recovery room. In total, 191 women underwent hysterectomy. 36% underwent vaginal hysterectomy, 48% had a laparoscopic assisted, and 17% had an open approach. The mean age and body mass index were 50 years old and 27 kilograms per meter squared, respectively. Most hysterectomies were performed in premenopausal women, and the majority of all hysterectomies were for benign indications. Approximately 21% were for pain-related reasons. The median cumulative opioid consumption for all hysterectomies was 75 milligrams of oral morphine equivalents. The median 24-hour postoperative opioid consumption was 16 milligrams of oral morphine equivalents. In multivariate analysis, predictors of increased cumulative opioid consumption included baseline pain scores using the NRS scale, PSQ minor scores, preoperative use of pain medication, and open hysterectomy. Specifically, every additional point on the NRS score corresponded to 2.5 more milligrams of oral morphine equivalent. Every additional point on the PSQ minor score resulted in 4 milligrams more of OMEs. Every additional use of a preoperative pain medication resulted in 9 milligrams more OME, and the use of an open approach corresponded to 59 milligrams more of oral morphine equivalents. In conclusion, predictors of cumulative postoperative opioid requirements for hysterectomy include preoperative NRS scores, PSQ minor scores, number of preoperative pain medications used, and surgical approach. This information can be used to create a predictive calculator to individualize perioperative interventions, optimize postoperative pain management, and tailor opioid use, all contributing to efforts against the opioid crisis. Thank you.